Hello everyone, myself Dr. Samir. Today we are going to discuss on the international consensus regarding the optimal use of polymyxins. Polymyxins were first used in 1950s and then were stopped. They were again reintroduced in the 1980s and are now used as salvage therapy for untreatable gram-negative MDR and XDR infections. Since their reintroduction, significant confusion remained regarding their use due to the difference in formula. Hello everyone, myself Dr. Samir. Today we are going to discuss on the international consensus regarding the optimal use of polymyxins. Polymyxins were first used in 1950s and then were stopped. They were again reintroduced in the 1980s and are now used as salvage therapy for untreatable gram-negative MDR and XDR infections. Since their reintroduction, significant confusion remained. Hello everyone, myself Dr. Samir. Today we are going to discuss on the international consensus regarding the optimal use of polymyxins. Polymyxins were first used in 1950s and then were stopped. They were again reintroduced in the 1980s and are now used as salvage therapy for untreatable gram-negative MDR and XDR infections. Since their reintroduction, significant confusion remained regarding their use due to the difference in formulations, different conventions used to describe the dosings, uncertainties regarding susceptibility testing. These guidelines provide a practical framework for the treating of MDR and XDR gram-negative infections. International experts from various societies like the ACCP, ESCMID, IDSA, ISAP, SCCM, SIDP collaborated to form a consensus statement regarding the use of polymyxins. They reviewed the literatures regarding 20 topics and subsequently made 34 recommendations. So, I with Dr. Arun Rath will try to discuss these topics in a question and answer session. Hello, Dr. Arun. So, how should the susceptibility be tested, and what are the minimum inhibitory concentration breakpoints for polymyxins to guide therapy?
First, to answer regarding how susceptibility testing should be done, the UCAS and the CLSI came up with a recommendation that standard microdilution broth methods should be used and Muller-Hinton broths should be only used. And regarding the which composition of colistin should be used, they suggested that colistin sulfate salts must be used rather than colistin methanosulfate salts because they are very slowly converted to the active compound colistin in vitro. And regarding the MIC values, the CLSI and the UCAS have made recommendations for Acinetobacter and Pseudomonas only. The MIC values for Enterobacteriaceae could not be derived because of lack of data. CLSI and UCAS both recommend a MIC of less than 2 milligram per liter as sensitive, whereas CLSI states that more than 4 milligram per liter as resistant for Acinetobacter and Pseudomonas. The UCAS, however, differs and states that more than 2 milligram per liter MIC is resistant for Pseudomonas and Acinetobacter. However, they have also formulated an epidemiological cutoff value for Enterobacteriaceae family with whatever data they have, and both UCAST and CLSI have stated that less than 2 microgram per liter is sensitive and more than 2 microgram per liter is resistant for Enterobacteriaceae.
So, is there a recommended kinetic pharmacodynamic therapeutic target for maximization of efficacy for colistin and polymyxin B?
Definitely. Although therapeutic drug monitoring is still in very early stages in India and is not practicable everywhere, but the concentration time curve for 24 hours at a steady state for colistin should be 50 milligram hour per liter. That is the maximal tolerable dose. And for polymyxin B, because it has a better toxicodynamic profile, it is a bit higher from 50 milligram hour per liter to 100 milligram per hour per liter.
So, for colistin methosulfonate, what is the relationship between different dosing units in the literature?
Yeah, there was a confusion regarding the units of dosing. The Europeans prefer to mention polymyxin colistin dosings in international units. The Americans prefer to mention it in milligrams of colistin based activity. Both of them are acceptable according to the guidelines, but in some countries the colistin is mentioned as milligrams of colistin methane sulfate. They have discouraged to prescribe dosing in forms of milligrams of colistin methane sulfate. They have standardized this because to ensure safe prescriptions.
So, is there any preference of using any one form of polymyxin over the other?
Yeah, they have recommended to preferentially use polymyxin B wherever possible over colistin. The reason being that polymyxin is an active drug and colistin is applied as a prodrug. Another reason is that polymyxin B has lesser risk of acute kidney injury, whereas colistin has higher risk of acute kidney injury. And thirdly, therapeutic drug monitoring is better achieved when you are given active drug rather than a prodrug. So, for easiness of the therapeutic drug monitoring, it is also advisable to give polymyxin B as preferentially over colistin. The exception to that is urinary tract infections, because polymyxin B is hardly renally eliminated, so we prefer colistin over polymyxin in urinary tract infections.
So, do we need to administer any loading dose for colistin methamphetamine when I initiate any therapy?
Yes, the guidelines recommend a initial starting dose of 9 million units infused over 30 minutes to 1 hour as a loading dose. Because the rationale behind it is a prodrug and it takes some hours to days to achieve steady state concentration. So it is preferable to give a loading dose. And moreover, the achievement of steady state concentration also depends upon the brands that we use and batches. It also differs from batches, so it is safe to administer a loading dose of colistin, although there is a risk of developing AKI with a loading dose, but the data regarding that is unclear and the guidelines favors administration of loading dose.
So, what should be my initial daily maintenance dose of colistin methamphetamine in patients with normal renal function?
In normal renal function, the recommended dose is 9 million to 11 million units per day in two divided doses infused over 30 minutes to 1 hour.
So, do I need to change the maintenance dose in patients with renal function for colistin?
Yes, they have provided us with a table according to the creatinine clearance of the patients. It starts from 4 million units per day for patients with zero creatinine clearance, and up to 11 million units per day for patients with normal renal clearance.
Okay. So, does renal replacement therapy in patients receiving colistin, does that change the dosing of colistin?
Yes, they have very clearly defined the doses of colistin in various types of renal replacement therapy. For example, in intermittent hemodialysis, the dosing is different. For SLED, the dosing is different. For CRRT, the dosing is different. For intermittent hemodialysis, they have recommended a 4 million units per day on non-dialysis days and an additional 1.2 million units of colistin on dialysis days, which is for a 3-hour session, and one additional 1.6 units of colistin for a 4-hour session. For SLED, they have stated that the dose should be increased by 10% of the dose, 10% of the provided dose according to the creatinine clearance per hour of SLED. So if you do a 10-hour slate, the adjusted dose will be 100% more than what is prescribed according to the creatinine clearance. So, and in CRRT, they have recommended a fixed dose of around 13.3 million units per day to be given in two divided doses.
So, coming to polymyxin B, do we need to administer a loading dose to the patient?
Yes, they have recommended administration of a loading dose of 20 to 25,000 units per kg over 1 hour. The rationale behind this is that they have reviewed various literatures and they have found that this loading dose achieves the desired MIC in around 70 to 90% patients, whereas the lesser dose, 12,500 milligram per kg, it achieves desirable MIC in only 50 to 60% patients. So yes, polymyxin B is also given in a loading dose of 20 to 25,000 units per kg over 1 hour.
So, what is the recommended maintenance dose of polymyxin B in patients with normal renal function?
The recommended dose is 12,500 to 15,000 units per kg every 12 hours, infused over 1 hour.
And in patients with renal impairment, what will be the adjustment needed in the doses of polymyxin B?
They have not suggested any renal dose adjustment for polymyxin B. They have recommended the normal maintenance dose in patients with renal impairment also.
And does the dosing of polymyxin B maintenance dose change in patients on renal replacement therapy?
No, because polymyxin B is not renally eliminated, it is also not eliminated by dialysis filters. So the polymyxin dose doesn't change with renal replacement therapy also.
So now coming to the therapeutic drug concentration in the blood, is there any recommendation regarding these concentrations of polymyxin B and colistin?
Yes, wherever available, it should be used. It should be used because these polymyxins have a very narrow therapeutic index. So it is wise to use therapeutic drug monitoring wherever applicable, and the guidelines recommends using.
So what strategies can be used to decrease the incidence of acute kidney injury in patients receiving polymyxin B or colistin?
Yes, this was a very important question raised. They have enlisted a few strategies which can minimize polymyxin induced AKI. First is doses higher than the maximum recommended doses should not be given. Second is concomitant use of other nephrotoxic drugs should be avoided, especially vancomycin, rifampicin, NSAIDs, ACE inhibitors. This should be avoided. Contrast agents should be avoided in patients receiving colistin. These are some of the modifiable risk factors, which could be avoided in patients receiving polymyxins. They have also identified certain unmodifiable risk factors like hypoalbuminemia and age and weight of the patient, which are risk factors for polymyxin induced AKI.
Now, suppose my patient receiving either colistin or polymyxin B develops acute kidney injury. So, should I come down on the doses?
Yes, doses should be reduced according to the recommended renal dosing table. But beyond that, doses should not be reduced, particularly if it is being treated for a life-threatening infections or the MIC of the susceptible organism is more than one. We may consider to reduce the dose if the MIC is less than one.
Now, my patient develops carbapenem resistant Enterobacter C or a carbapenem resistant Pseudomonas infection. So, should we go for a monotherapy or a combination therapy using either colistin or polymyxin B?
Actually, there was no consensus on these among the committee members, so they went for a vote, and they recommended combination therapy for all carbapenem resistant infections like carbapenem resistant Enterobacter C, carbapenem resistant Pseudomonas, and also for carbapenem resistant Acinetobacter. They recommended that polymyxins should be used in combination therapy whenever there is another susceptible agent available. In case there is another susceptible agent is not available, we can use another non-susceptible agent with a lower MIC. This recommendation is applicable to both CRE and CRPA, Pseudomonas aeruginosa. But for carbapenem resistant Acinetobacter infections, they have recommended against the use of combination therapy if more than one susceptible agent is not available. So for carbapenem resistant Acinetobacter infections, we should use combination therapy only with another susceptible agent. We should not use another non-susceptible agent as a combination therapy.
Should inhaled polymyxins be administered to patient of HAP or VAP? And if so, which agent is preferred?
Yes, the guidelines recommend the use of polymyxins as an adjunctive agent to IV polymyxins, in hospital-acquired pneumonia or ventilator-associated pneumonia. Although there is a weak recommendation and the level of evidence is poor, but still they have made a recommendation. And there is no clear-cut choice between the use of colistin or polymyxin B. Any one of the agents can be used as an inhaled agent.
Okay. So coming to our last question, what is the role of polymyxins, intrathecal or intraventricular polymyxins, for treating ventriculitis or meningitis?
Yes, the guidelines recommends the use of intraventricular or the intrathecal use of polymyxins in MDR or XDR gram-negative meningitis or ventriculitis. They have recommended a dose of 1,25,000 million units of colistin or 50,000 units of polymyxin B. Either of them can be used intrathecally or intraventricularly. Because the data regarding the use of polymyxin B is limited, so they have recommended to use colistin preferably.
Okay, so thank you very much, Dr. Arun.
Thank you.
So, and thank you, audience. I hope now you have developed a good knowledge about regarding the use of polymyxin and colistin in ICU patients in multi-drug and extremely drug-resistant organisms, gram-negative organisms. So thank you very much for paying attention, and please like and share this video. Thank you.